Assalamu alaikum warahmatullahi wabarakatuh. Welcome, dear colleague. Many of our colleague has asked me to repeat this lecture, which is talk about the CSF flowmetry and its clinical application. And I think it is one of the most important lecture in our radiology course. So I will repeat the lecture today in an English, and I will discuss some cases, some important cases that directly apply the CSF flowmetry, and how can apply this CSF flowmetry in the real life clinical practice in the last of the lecture, inshallah. At first, we will talk about the basic of the sequence of the CSF flowmetry, which is called phase contrast MRI, and then we will discuss the clinical applications of the CSF flowmetry, which include normal pressure hydrocephalus, Chiari type 1 malformation, aqueductus, stenosis, arachnoid cyst, and shunt tube. And these are the most important clinical applications for the CSF flowmetry. There are other clinical application, but less important than this one. At first, the phase contrast, which is the a basic sequence of the CSF flowmetry. The phase contrast MRI can detect the pulsatile CSF motion and its direction. And this is one of the importance of the CSF flowmetry. Actually, in this sagittal image, we can see in this sagittal phase contrast image, we can depict the pulsatile motion of the CSF flow in the CSF spaces anterior and posterior to the brainstem and in the foramen magnum, and also in the aqueduct of Sylvius. The CSF motion, as we noticed here, is appeared as an alternating bright and dark signal. It is a bright signal followed by dark signal, bright signal followed by dark signal. This is the motion of the CSF flow appeared in the phase contrast MRI. This is the normal CSF flow appear as an alternating dark and bright signal. Why it's appear as a dark and bright signal, alternating dark and bright signal? Because it's the CSF flow, its direction is influenced by or affected by the cardiac motion. In the cardiac systole, this is the CSF flow motion. In the systole, the CSF move from caudal to cranial, while in the diastole, the CSF flow move from cranial to caudal. So if the motion appear in from cranial to caudal, it will appear as a bright signal for say. So if the caudal is if the motion is reversed, so the CSF flow will appear dark signal, the opposite color. So these two colors reflect the direction of the CSF flow. So in the phase contrast, it is not just can depict the motion of the CSF flow. We can depict this is there is a motion or there is a CSF flow in these sites, but also it can depict the variation or the direction of the CSF flow. So this is one of the first important application of the CSF flow is to detect that there is a CSF flow in these sites, and it shows that the free communication or free direct or free movement of the CSF flow and its direction by depicting the alternating bright and dark signal. So as we say here that the relation of the CSF flow is intimately related to the cardiac pulsatility, so the study should be cardiac gating. Also, the phase contrast MRI also can depict not only the CSF motion, it also can measure the velocity of the CSF flow. It can measure the velocity of this motion by applying ROI or region of interest. This ROI or region of interest at any specific site, I want to measure the CSF flow at this site. So when I apply this ROI, or a region of interest, for say here at the aqueduct region of the aqueduct of Sylvius, I can measure the velocity of the CSF flow at this site. How can this done? Can this done by just apply a application of this ROI, and by the software it usually generate this curve and a table and certain parameters here. One of the most important parameter that can be generated is the stroke volume, and this is one of the important parameter, as we will discuss in the clinical application in the next slides. So this is how the CSF flow can measure the velocity of the CSF flow. There is an important issue about measuring of the velocity of the CSF flow, is to proper select of the velocity encoding gradient. With this is one of the parameter in the phase contrast study. We should proper select this velocity encoding parameter to be matching the CSF flow velocity. The normal CSF flow velocity is from 5 to 8 centimeter per second. So the velocity encoding parameter, which is included, which is one of the parameter when we do the CSF flowmetry study, we should choose this parameter close enough to this velocity, because if the parameter here is much lower than the normal CSF flow, it will reduce this artifact, which is called aliasing artifact. You can see here, this is an aliasing artifact. This means that the velocity encoding parameter that I choose is much lower than the anticipated velocity. Also, we should, if this parameter is much higher than the CSF flow velocity or the anticipated CSF flow I measured, it usually does not depict the velocity. It can't depict this velocity and can detect this velocity, and so the velocity encoding parameter should be putted or chosen matching the anticipated CSF flow. So the phase contrast MRI study, in brief, it is have two values. It can depict the CSF motion and its direction, and this is called qualitative assessment, and also can measure the velocity of this CSF flow motion, and this is called quantitative assessment. This is called qualitative assessment by seeing the motion of the CSF flow, and this is called qualitative assessment by measuring the velocity of the CSF flow. So in this, this is the phase contrast, and this is the basic of the CSF flowmetry. In this is the clinical, we will start discussing the clinical application of the CSF flowmetry. This is the clinical application in the CSF flowmetry, which is the normal. First one is the normal pressure hydrocephalus. The normal pressure hydrocephalus, actually it is a type of chronic hydrocephalus in which the CSF pressure become normal. So this is its name is normal pressure because it is a type of high communicating hydrocephalus, but the pressure of the CSF, when we measure the pressure of the CSF, it is normal. So it is called normal pressure hydrocephalus. The normal pressure hydrocephalus comes with a classic clinical triad, which is formed of dementia, incontinence, and gait disturbance. This is a very typical classic triad and very classic in clinical practice, and usually the clinician send the patient suspecting normal pressure hydrocephalus. In the normal imaging of the CSF flowmetry, in the normal MRI imaging for the normal pressure hydrocephalus, it has a certain criteria that is characteristic for normal pressure hydrocephalus, and we can by this feature suggest that the patient have normal pressure hydrocephalus. These features include that the dilatation of the ventricular system that is out of proportion to the extra-axial CSF spaces. In the sagittal image, we can see exaggeration of the signal void along the aqueduct of Sylvius, and there are other features in normal MRI, routine MRI sequences that can suggest that there is a normal pressure hydrocephalus. This is the most two important features: the dilatation of the ventricular system that is out of proportion to the extra-axial CSF spaces, and the exaggeration of the signal void that is seen along the aqueduct of Sylvius, and reveal that or reflect the hyperdynamicity of the CSF flow along the aqueduct of Sylvius. In the MR CSF flowmetry, we can usually confirm the diagnosis of the normal pressure hydrocephalus. This feature is usually suggestive, but in normal pressure hydrocephalus, we can be sure that these patients have a normal pressure hydrocephalus, and this can be done by the quantitative assessment of the flow in the aqueduct of Sylvius. We can put ROI, or region of interest, at the aqueduct of Sylvius and measure the stroke volume, and if the stroke volume is more than 42 milliliter per second, this is diagnostic for normal pressure hydrocephalus. It is not only confirmed the diagnosis of normal pressure hydrocephalus, it also affects the management, because if the stroke volume is more than 42 millimeter per second, these patients are best responsive to shunt tube. The management of the normal pressure hydrocephalus is usually by insertion of the shunt tube, and the patient have a dramatic response and very good response to application of the shunt tube. And the patient that have a best responsive for the application of the shunt tube, whose stroke volume in the CSF flowmetry is more than 42%, 42 milliliter per second. So this is the application of the CSF flowmetry in patient of normal pressure hydrocephalus. They confirmed the diagnosis and proper selection of patient who best responsive to shunt tube insertion. And this depend only or depend on upon the quantitative assessment of the CSF flowmetry study. The second application in the CSF flowmetry in the Chiari type 1 malformation, and as we know, in Chiari type 1 malformation, there is a crowding of the posterior foramen magnum and low-lying tonsillar tonsils that is peaked inferiorly. This is the classic features of Chiari type 1 malformation. The role of normal pressure hydrocephalus in this Chiari type 1 malformation is by confirming the diagnosis of Chiari type 1 malformation, and this can be done by the qualitative assessment of the CSF flow along the foramen of magnum. We can see here, this is a sagittal image, we can see here that there is a free flow in the CSF in the foramen magnum anteriorly, but it is absent of the CSF flow posteriorly. So there is or impedance of the CSF flow posteriorly in the posterior fossa. So there is an impedance or absence or affection of the CSF flow or absence of the CSF flow posteriorly in the foramen of magnum, and this confirms the diagnosis of the Chiari type 1 malformation. It is not only confirmed the diagnosis of Chiari type 1 malformation, it also, these patients who had an impedance or absence of the CSF flow in the foramen of magnum as this patient are usually the patient who best responsive to surgery. These patients, when we do a surgery for these patients, it usually have a very good response, and they have a very good prognostic factors. So it is important before surgery in patient with Chiari type 1 malformation to do CSF flowmetry, because if these patients have an impedance of the CSF flow along the foramen of magnum, these patients are candidate for surgery because they have the best responsive to surgery. These patients undergo a surgical intervention, and we can see there is a restoration of the CSF flow at the foramen of magnum posteriorly, and the patient usually have a very good response after surgery. So in the Chiari type 1 malformation, the CSF flowmetry usually depend upon the qualitative assessment, not a quantitative assessment. We don't measure anything. We just depend upon the qualitative. We depend upon the motion of the CSF flow along the foramen of magnum. So this is the role of the CSF flowmetry in Chiari type 1 malformation. The role of CSF flowmetry in aqueductal stenosis, we can see that we can suggest that there is an aqueductal stenosis in MRI images, normal MRI images, by detection of there is a supratentorial hydrocephalic changes, and there is a dilatation of the third ventricle while the fourth ventricle is not dilated. And we can see here that, so we usually suggest that the obstruction is usually at the level of the aqueduct of Sylvius. But sometimes we can also see that there is a small web in the aqueduct of Sylvius, but usually we are not sure about this. We can see, we always suggest that the level of obstruction is at the level of aqueduct of Sylvius, but we are not sure about this. In the CSF flowmetry, we can confirm the diagnosis of aqueductal stenosis by doing the qualitative assessment of the CSF flowmetry and see that there is an impedance or absence of the CSF, pulsatile CSF flow along the aqueduct of Sylvius. So this is means that there is an obstruction along the aqueduct of Sylvius, and this can confirm the diagnosis of the aqueductal stenosis. Depending upon the qualitative assessment, we don't measure anything in this clinical application. We depend only about the qualitative assessment, and if there is absence or presence of the pulsatile motion along the aqueduct of Sylvius. The third application is, or the fourth application is in the arachnoid cyst. We know about the arachnoid cyst. They are extra-axial cystic lesions that have a mass effect on the surrounding. But it is important to know if this arachnoid cyst is communicating or not with the extra-axial spaces, if this cyst will manage it surgically. Preoperative, it is must too important. If this arachnoid cyst will have a symptoms and causing a significant mass effect, seizure or hydrocephalus, or if these cysts are symptomatic and the surgical intervention is decided for these arachnoid cysts, we must do a CSF flowmetry to know if this cyst is communicating or not with the subarachnoid spaces. This can be done in the CSF flowmetry by, if this is the cyst, we can see that the pulsatile motion of the CSF flow pass within the cyst. So this means that the cyst is communicating with the subarachnoid space. Also, this is an example for arachnoid cyst here in the spinal cord, and we can see that the alternating pattern of dark and bright signal seen within the cyst. That means that the cyst is communicating with the subarachnoid space, and this is a very important or crucial before surgical intervention for these arachnoid cysts. And we can also depict the site of the communication, it usually show jet at the site of the communication. So in the CSF flowmetry we can depict that the cyst is communicating with the CSF subarachnoid space, and we can also detect the site of the communication by the presence of the jet, usually indicate the site of the communication. And also in this application it is the role is usually depend upon the qualitative assessment, not a quantitative assessment of the phase contrast study of the CSF flowmetry. The last clinical application of the CSF flowmetry in shunt tube. If you want to know if the shunt tube is patent or not, we can do a CSF flowmetry along the applied shunt tube, and we can see if there is a flow of the CSF within the shunt tube or not. It appears as we see here, this is the tube, and we can see this is a bright signal seen within the applied shunt tube. So this means that the shunt tube is patent, and as we depict here, this shunt tube usually have only one direction. There is no alternating bright and dark signal. There is only bright signal like this, and this denote that the aqueduct, that the shunt tube is patent, because it has only a one direction. It usually have a valve, and usually the direction of the CSF flow is usually unilateral, so it has a no pulse style movement. So we depict, or we anticipated, or we are expected that the CSF flow within the shunt tube is usually unilateral and appear as a bright signal like this. So we can assess the patency of the shunt tube also by depending upon the qualitative assessment of the force phase contrast MRI study. So these are the most important clinical application of the CSF flowmetry, is confirming the diagnosis of normal pressure hydrocephalus by measuring of the CSF flow along the aqueduct of Sylvius, and measuring the stroke volume. If it is more than 42%, it means that the stroke volume, that is hyperdynamic, and this is normal pressure hydrocephalus, and these patients are best responsive for shunt tube insertion, and this is depend upon the quantitative assessment. The other remaining applications are usually depend upon the qualitative assessment. In the aqueductal stenosis, we can see absence of the CSF flow along the aqueduct of Sylvius. In the Chiari type 1 malformation, there is absence of the CSF flow at the foramen of magnum, and usually these patients are best responsive for surgery. And in the arachnoid cyst, if the cysts are communicating or not with the subarachnoid space, and the shunt tube, if the shunt tube is patent or not. And all these features or these clinical applications depend upon just only the qualitative assessment, not the quantitative assessment of the CSF flowmetry study. So these are the most important clinical application for the CSF flowmetry. And here we will discuss some cases that depend upon the CSF flowmetry. Okay. This is the first case here. This child have an apparent, as we see here, this is digital T2 weighted images we can see here that there is a low tonsillar herniation. As we see here, this is the tonsil is low lying here and pointed, and there is an axial image. There is a crowding of the foramen of magnum. So this means that these features are keeping with Chiari type 1 malformation. As we see here, this is the CSF flowmetry study for this patient. This is the CSF flowmetry for this study. We can see here that there is an impedance or absence of the CSF flow at the foramen of magnum posteriorly. So this means that there is an impedance of this CSF flow. This means that this patient confirmed the diagnosis of Chiari type 1 malformation, and this patient is candidate for surgery and usually will be responsive for best candidate for surgical intervention. This patient here is an example for the Dandy Walker malformation. There is a large retrocerebellar cyst with absence of the vermion. So this is a typical example for Dandy Walker malformation. Dandy Walker malformation usually associated with an aqueductal stenosis, and as we see in this patient, there is an element for hydrocephalic changes, and there is application or applied shunt tube here that is usually drain these hydrocephalic changes, but there is a residual minimal periventricular high signal that reflect CSF permeation, and the applied shunt tube here is indication for that there is a hydrocephalus, that there was a hydrocephalus. There is no more hydrocephalus because the shunt tube is applied. This is the sagittal image. Here we can see that it could be, there is narrowing of course of the aqueduct of Sylvius, but it could be some sort of web here or web here, but we are not sure if there is an aqueductal stenosis or not. So we did CSF flowmetry for this patient. This is the CSF flowmetry for this patient, and we can see that there is absence of the CSF flow here along the aqueduct of Sylvius. This means that there is an impedance or absence, there is an obstruction of the CSF flow at the aqueduct of Sylvius, and confirm the diagnosis of the aqueductal stenosis. The last case here is it is an example for the normal pressure hydrocephalus, that the patient have a dilatation of the ventricular system that is out of proportionate to the extra-axial CSF spaces. So this suggested for a hydrocephalic, so normal pressure hydrocephalus in of course, if there is a clinical, especially if there is a clinical history of the classic triad. We also can see in the sagittal there is an exaggeration of the signal void along the aqueduct of Sylvius. So we did a CSF flowmetry for this patient, and in the normal pressure hydrocephalus we are targeting to measure the CSF flow along the aqueduct of Sylvius. So we put a ROI along the aqueduct of Sylvius, and as we see here, there is a curve present generated and tapered with a certain value. Some machine produce the stroke volume automatically, and other usually needs to calculate this manually. In Philips machine, this will be produced. We can calculate stroke volume by adding the flow values here. That is with negative. That means that that the flow in the systole, its stroke volume is equal the mean systolic flow multiply the duration of the systole. The systole here is usually by the negative value in the curve that is below this line. So this is the systole. So we add the flow values that is with the negative. This means that the flow value in the systole, we add this number and this number and this number and this number, all the negative value, and divide it along its number. For say this is 1, 2, 3, 4, 5, 6. So we add this 6 number and divide it by 6 to obtain the mean flow, mean systolic flow, and divide and multiply this by the duration of the systole. Here the duration of the systole is from 1050 to 550, so it means that the duration is about 500 milliseconds. So by multiplying 500 milliseconds by the mean systolic flow, this will result the stroke volume. And as we see here, these values are usually large, so the number will produce is usually more than 42 milliliter per second. This means that the flow here is hyperdynamic, and this patient confirmed the diagnosis of normal pressure hydrocephalus, and these patients are candidate for shunt tube insertion. So this was all about the CSF flowmetry and its clinical application. I hope it was a beneficial and helpful lecture, and meet you soon inshallah.